Okay. Good morning to all of you from Madras Medical Mission. I am Dr. J. Alan. Along with me is Dr. Nandakumar and Dr. Ashish Chopra, consultants at Madras Medical Mission. Today, for MedStream 360, we are going to present a case of thoracic aortic aneurysm. It's a saccular aneurysm. We are going to show the endovascular closure of this aneurysm. So the history, this is a 61-year-old gentleman with systemic hypertension and a smoker. He went to his physician for palpitation and routine investigations on his chest X-ray. You can see a large shadow on the left side of the heart, which most probably is a descending thoracic aortic aneurysm. Hence, a CT aortogram was done, which showed a saccular long descending thoracic aortic aneurysm measuring 6.5 into 6.3 with a large intramural thrombus in it. Any thoracic aneurysm more than 5.5 needs to be dealt with, and since this was 6.5, 6.3, chances of rupture is high and it needs endovascular closure. The length of the aneurysm was 104 millimeters. The diameter was 6.5 into 6.3 at the maximum expansion point, and there was a crescent-shaped thick intramural thrombus 36 mm in the aneurysm. It was 63 mm away from the left subclavian and 120 millimeter above celiac artery, giving us good landing zones above and below. So this is the CT picture of the thoracic aneurysm. You can see the saccular aneurysm bulging to the left on the greater curvature. Next. Now, if you see the diameter of the aorta in the landing zone above is around 34, and the diameter of the aorta below was around 28. So if you see the access size vessels, the right common femoral is 11.4 into 11.9 and left common femoral was 11 into 10.4. Both iliacs were around 11 millimeter. So we had good sized access vessels, and we are planning to pre-close with the 3 proglide device the right common femoral access. So we have taken 3 accesses, actually 2 for the procedure. One, the anesthetist has taken the left radial access. We have taken the right femoral artery and the left femoral artery, common femoral. Both were done with ultrasound guidance. And then we had a 6 French sheath left in the left side, and a 6 French sheath was also put on the right side. 3 proglide sutures were placed in position, and now we are live for you from here onwards. Initially, first we are planning to do a coronary angiogram because previously we had a bad experience of doing a primary after a TEVAR procedure. Since he is hypertensive, 61, with evidence of atherosclerosis, we are going to do an angiogram before proceeding.
We have given 5,000 heparin, sir. Maybe after putting the large sheath, we will give the rest of the heparin.
This is a large bore access. The size of the device is 24 French. So we have given 5,000 heparin. We'll be giving the remaining heparin balance later on. And since it is 24 French, we have placed 3 proglides before proceeding to do the intervention. We have put 3 proglides at 10 o'clock, 2 o'clock, and 12 o'clock. Hello. As the aorta is dilated, JL 3.5 is finding a little short. Maybe a 4 would have fit in better. A 4. Okay. LED mid after the diagonal. Okay, the coronary's LED shows a lesion after the diagonal, and there is some disease in the diagonal also.
Prabhu, just check the pressure line. Is it damping or is it a okay pressure?
Okay. The circumflex also OM shows 40-50% lesion in the OM one. But anyway, not significant enough to be dealt with now. Pressures, yeah, 100. அதில் 80 தான் காட்டுது. Intra-arterial 80 தான் காட்டுது. நீங்கள் எதாவது சொல்லணும்னா நடுவில் சொல்லுங்க.
Oh.
அதில் 100 காட்டுது, இதில் 80 காட்டுது. We are just flushing the lines as there is discrepancy on the pressure recorded non-invasively and on the monitor. And now taking the right Judkins to hook the right coronary artery.
What is our plan now regarding coronary artery disease? Are we going to fix it first and then go for the endovascular, or at the end of the same procedure, or would you like to stage the procedure?
No, we would like to stage it. We would first go ahead with the endovascular procedure since we are all prepared for it. Since it's chronic coronary syndrome, patient does not have any symptom, we can deal with it at another sitting later on. Okay. The right seems to be okay, except for some slow flow in the PDA territory.
Pigtail, huh?
Ah.
Hmm.
So before deciding on the device selection, which I have already done by CT, we'll take a marker pigtail through the left common femoral artery axis, and this marker pigtail you can see has markings for every 10 millimeter or 1 centimeter. So this will help us to measure the length of the aneurysm.
Every time as we are going, we need to be careful we are not entering the aneurysm sac. Here the aneurysm sac is thrombosed. Sometimes it may have a space where our catheter can go and disrupt the aneurysm.
If that happens, you'll have embolization to the both legs and you'll have a purple toe syndrome. So the manipulation of the wire and catheter in the aneurysm should be done carefully.
So now from where we are going to take the shot, from the ascending aorta or arch?
Uh, I mean, if we take from the ascending aorta, most of the dye will be wasted in the
So
neck
I will pull
vessels.
back.
So since we are 60 millimeter away from the subclavian, we can take it anywhere
I
in the
think from
descending
here.
aorta or at the origin of the subclavian.
Okay, I think this should be okay.
Ah,
So can we keep 20?
pressure.
25, okay. 25 is okay, right? 25 at
Pressure.
50.
Oh, ಇದೆಲ್ಲ connect.
We'll connect here. Okay, and I think
Elevo. Elevo. Elevo 30, 40.
the reason why we are going into the left anterior oblique view is to open all the major branches of the arch vessel so that we can identify the landmark, proximal landmark, how many centimeter from the left subclavian artery. That is our idea now. Okay. So are we going to take a DSA or we are going to follow it up? We'll take one
DSA.
DSA here.
Okay, we'll take a DSA. Just cut anteriorly, show a little posteriorly. The aneurysm is extended.
And for
behind.
anesthetist, when we say, you need to have a breath hold when we say.
Show a little posteriorly. Ah, yeah. Okay, fine, fine, fine.
Okay. Okay, breath hold. Sini. Start breathing. Okay, we will go a little down and we will take one more shot to find the distal landing zone. Since the aneurysm is thrombosed, we couldn't see the cavity. We are seeing only the luminogram. And in the CT, can you put that CT image previously? Next. Yeah, if you see, even in this image of the CT, the luminogram did not show any aneurysm. We can see a thrombosed aneurysm on the right side of the image where the arrow mark is seen, because the contrast is not entering the aneurysm. So we couldn't see, but we can see a small pouch, a small pouch projecting on the major curvature.
Okay. This is the place of the aneurysm.
Yeah.
So aneurysm will be projecting like this. We'll take another picture to see the lower
Distal
landing zone.
So in the same LAO, can you come little down? Yeah, enough. Yeah, now I think in this particular image we can see the diaphragm also. This is a plain LAO, right? Okay. This should be okay. So once again, injection, you are ready? And please hold the breath. Cine. So here we can clearly see the distal landing zone. Start ventilator.
So the distal landing zone seems to be healthy.
Okay, deactivate the DSA. Show me above. Okay, let it be here. Let's start upgrading our
device size.
sheath.
So now we have to take a call on what size device we are going to deploy. We have good proximal neck and distal neck. We are 60 millimeters away from the subclavian artery, and so what we have decided is we are going to take a Valiant Captiva stent graft, 36 diameter above, 32 millimeter above, 150 millimeter length. So since above we have 60 from the left subclavian, we'll place it some 20 to 30 millimeters after the left subclavian. So we have a 30 to 40 millimeter landing zone above. And then when we place it, the aneurysm is 100 millimeter. We'll have another 30-40 millimeter sealing zone below also. So we have adequate sealing above and below. So the device that we have chosen is a 36 into 32 into 150 Valiant Captiva.
So the reason for choosing 36-32 because the proximal landing zone measures, pass the wire, measures 31 millimeter, and distal landing zone measures 26 to 27 millimeter. So how you oversize generally in aneurysm or dissection?
In aneurysm, we can oversize by 20 to 30%. Whereas for dissections, we oversize only by 10%. So, or aneurysm, you oversize by 3 to 4 millimeter than the diameter, and dissections you oversize by 1 millimeter.
We can see just now wire try to enter the cavity for a moment. What we are doing now, for using a 035 Teflon wire, we are keeping a Judkins right catheter in the upper descending thoracic aorta, and to put the stiff wire to upsize the sheath size. This Amplat super stiff wire 035 exchange length 300 centimeter, right? 260, okay.
One should never take the stiff guide wire directly. You should always take it over a catheter so that you don't traumatize the thrombus in the aneurysmal segment.
Ashish, can you take over? So we are going to dilate the right femoral axis using a universal dilator. You can see this universal dilator. So it's progressively. So can you explain the universal dilator?
So I mean, see, now we had a 7 French sheath in, and the device is 24 French. You cannot straight away take a 24 size device. It might tear the artery. So to prevent that from happening, we have to progressively dilate the arterial orifice. So this progressive dilator, you can see it starts from 18 French here and till 24 or even 26, 27 you can dilate. So now suppose we are taking a 24 French device, maybe we can dilate it till 22 French and then take the device. So we have removed the sheath, we are giving groin compression, and now we are going to increase the aperture of the axis by the progressive dilator.
Can you hold the wire? Hold the wire, please. I need a half sheet to cover this place. Can you give me one half sheet? Half sheet.
Half sheet.
So if you watch here, we are going through the fluoro. And you see, first I'm going up to 18, then slowly going up to 20. And now I'm dilating slowly up to 22. It is better to keep for some time so that this dilatation happens nicely. So our sheath insertion is going to be little easy. The difficult part while inserting the sheath is especially in the that pelvic dip in the external iliac artery portion. I'm slowly removing the dilator and once again I'm inserting up to 22. Okay, the moment sheath is ready, I think we can pass the sheath.
The device will take without sheath while don't open 24.
Okay, so now the discussion what we are doing is, should we need a sheath or shall we take without the sheath? What is your opinion regarding the sheath and
I
sheathless?
think the 24 French outer diameter will be much larger. So we'll be creating unnecessary long, bigger end. What we'll do is we'll take the device straight, deploy the device, and afterwards, while removing the device, we'll put a smaller, say 22 French sheath, and then do the perclose closure.
So the device size is 24. If at all we are going to put, we need to put a 28 sheath. So it is going to unnecessarily increase the hole.
Increase the diameter.
Okay, so hence we are going straight with the device.
So we'll remove the dilator and then we'll take the
I
device.
think for the device, we need to change the wire to a Lunderquist wire.
No, this is
Ampler super
stiff. We can take it over it.
Okay, right. So that
the
means
only thing is we'll put the wire into the near the valves and then take this device. Lunderquist is stiff enough to take this device.
Okay, to do that, I once again, no dilator we cannot do. You just give me a JR or something to.
Now we have to prepare the device and take it in, or else
we have to keep the wire in the ascending aorta. Okay, I will hold the groin. In the meantime, no, you give me some sheets. Give me a 14 sheet.
Ah, 30. 120. Ah. So this is the Valiant Captiva device we are taking. It is 36 millimeter at the origin and 32 millimeter. So it's a tapered stent so that it adjusts to the size of the aorta which is coming down in this case.
After this, give me a JR or pigtail, whatever it is. You are ready, Ashish? Ashish, you are ready?
So we'll show you the preparation of the device, Sister Siri.
And just changing the leading edge here.
So
Hold the wire.
first we'll flush the side port. The device has to be kept facing up while flushing. Okay, it has got flushed. Syringe, saline. Then we'll have to flush the central lumen. Okay, it has got flushed. Now we are ready to take the device. Confirm that this is locked.
Show above. So coming back to the wire choice, since we are going to deploy it in the descending thoracic aorta, most stiffer wires are not required. Maybe Amplat superstiff wire itself is enough to track the device. Suppose if we want to deploy the device in the arch to begin with, to cross we require a better support. Hence during that time,
Show above.
okay, remove, can you remove this? And when you will use a Lunderquist wire, what are the scenarios you will use a Lunderquist wire?
Uh, Now when the device is of a much higher French, say 26, 27 French, when I need to place the landing zone in zone 0 or in the ascending aorta, then I would prefer a Lunderquist wire. It is a very stiff wire, traumatic wire, but when the support required is more, you'll have to use that wire.
And there is no big tortuosity in the abdominal aorta or
Ah,
iliac artery in this particular case. So
yeah,
I think this super stiff wire
yes,
should
should
enough
be
to.
enough.
Okay, shall we take the device now? Maybe we can give another 2000 heparin. We have given 5000, right? We can give another. Okay, 3000 heparin additional.
So sheath has to be removed.
So once you're ready, I will remove this one.
Yeah,
You are ready?
we are ready.
You just remove, I will hold this.
So we have removed the sheath. Now we are taking the Valiant Captiva device over the Amplacer super stiff wire. Okay. Once you are going to enter, you should wipe off the stent portion.
Can you hold the wire, sir? Somebody.
Yeah. Show follow from below.
Once it goes, you just show the wire also. Tip of the wire also.
It's a bulky device, finding some resistance in the iliacs. Now it has crossed. One should gently take the device up. Okay,
Okay.
okay, sure, thank you.
Now I want to see the wire at the ascending aorta. Is the wire is secured at the ascending aorta? Okay, now come back to pelvis. Yeah. Just track the dilator tip. Show above. Track the dilator. Is that is okay or?
Yeah, yeah.
So now, shall we take an injection and see where we are? Or I think
Yeah,
it should be okay.
yeah.
We will come to the LAO, but the position looks okay. So Dr. Arilan, you can take a call.
Yeah. So now we're going to repeat a shot. Roughly what we have seen is the figure of 8 which we see there. That is where the covered stent starts. So that should be in the junction of the arch and the descending aorta. So then we would be in the exact place. So
Maybe
that is what we have done.
should I go a little up or
Maybe a little up.
is that
Okay.
is okay?
Yeah. Ah,
Yeah, we need
yeah.
to show little above also. Please. Okay, connect this. Connect this. It's connected. Okay, right. Ready? Cine. Okay, you should have activated DSA. No problem. We can see this.
Okay.
Start
So,
breathing.
see, the aneurysm starts here, here, and up, up, yeah.
So now
Okay.
from the subclavian,
Ah,
pigtail marker shows 4 markers, which means
they
almost
are
like
40 millimeters.
40 millimeter. So maybe, yeah, we should go little, I think, in.
Yeah, yeah. We'll go a little in so that we get more landing zone proximally.
So by seeing the pigtail marker, I'm adjusting in
Yeah.
such a way, I'm a 20 millimeter from the.
Ah, ah,
So the covered portion should come there. So I think we see the covered portion as the figure of 8 markers in the device. So
yeah, 20. So
maybe I think we will take one another shot and we will take a call, and
DSA,
that
we'll
should be
take
a
a
DSA.
shot.
Okay, we'll take a cine and we will take a call. Breath hold.
Okay. Okay. Breath back. I think he'll be fine once we open up. It'll slowly open it up down. We'll go. Yeah. See, when we deploy a stent, it will try to come down due to windsock effect. So when it comes down, I think we'll be at the exact side.
Would
So
you
we'll
like to
start
check the
deploying.
distal portion, or is it okay?
I think
Anyway,
based on the
proximal.
length, it should be
Okay, right.
it should be right.
I think you take over the deployment.
So we'll start how to deploy this Valiant Captiva
You
devices.
take the fluoro controller.
Yeah. You have to hold this hand grip firm so that the stent doesn't move. Then you have to start unlocking this blue. So we'll start. We have to keep an eye whether the stent is moving or jumping down. So the sheath is slowly coming back. Now you see the figure of 8 has come out. We have to deploy 2 stents. So we have deployed 2 stents. The nose cap is still remaining captured. Okay, I'll deploy the third stent now. See, it jumped a little, but anyway, we have prepared for that. There are 2 ways of deploying this stent. One is you can keep up rotating this blue anti-clockwise, or you can, if you want rapid deployment, you can pull this trigger back and pull it so that it will get deployed. But we prefer to deploy it slowly. So I'll continue to show down. So now the device is fully deployed. Ah,
So store this and go to the nose cone. Yeah.
okay. The ಕೈ ಕೆಂಜ ಹಿಡ್ಕೊಂಡು. We'll remove up here. Okay. So now we are going to release the nose cone. You can observe the nose cone. It will slowly get.
Yeah. It's released.
Ah, okay.
Store that.
Okay. Now I'll bring this gray proximal portion back.
Wire. Hold the wire, Ashish. Gently push the wire.
Okay. Now we have captured the device and we'll slowly bring it out.
So 1 second. Show the wire on the top, please. Store this and show the wire on the top. Gently, can you push the wire? Yeah. Okay. Right. Okay, that's good. So now come down. Okay, now I think we jailed the pigtail. So
We'll
we'll
put a wire and remove the pigtail. Teflon wire. Okay. Okay. Now I'm going to gently pull out the pigtail at the same time looking for device migration. So the device is not moving. So I have now removed the jailed
store that.
pigtail.
Can you play once again?
Yeah. Now we'll, with the pigtail, we
Flush.
are going to re-enter the graft and then take another picture to look at a final result.
Okay, in the meantime, while Ashish is recrossing through the device, there are some questions we can see. I will read the question. What is the success rate of the recommended procedure? I hope the recommended procedure here means it is a TEVAR for this aneurysm, sacral aneurysm. So procedural success, I think they're asking. What do you think, sir? What is a procedural success?
Procedural success, I think it's almost nearly 100%. I mean, this is a straightforward, simple TEVAR. So that's why I would say 100%. In case it was a complicated TEVAR where you need debranching, fenestration, etc., then the success rate would come down a little. But otherwise, in a straightforward TEVAR like this, I think success is 100%.
Okay, one second. So now the best way to cross here is show a little down without the wire through the curved pigtail. If it cross, I think usually it enters. You see the wire is not there, just the curved pigtail going through the device. And the curve you couldn't see. Maybe if I pass the wire, I think you can recognize the curve. This is the curve. So maybe from here we can take a shot. Store that. What's the size and location of the aortic aneurysm in this particular case?
Yeah, this is a thoracic aortic aneurysm. It's a saccular aneurysm. The size was 6.5 into 6.3 and 103 millimeters in length.
So maybe this question has come because they could have seen the cine angiogram. They couldn't make out the aneurysm.
Aneurysm.
So the 6.5 centimeter you were saying, what measurement, sir, it is?
It is a CT.
It is a CT measurement of?
Short-axis measurement. We'll show you the CT images again and show the CT images of the cross section.
So it is a thrombosed portion and the lumen portion combined together. The measurement of the aorta or the aneurysm site is a 6.
Since it is fully thrombosed, you are not able to make it. Yeah. Now, just show the aneurysm on this side.
So,
see, that is the aneurysm. So since it is thrombosed, we are not able to make out the aneurysm here.
Okay, before going to the next question, we will take a shot, fluoro. So show me the top of the device, make it center. Our target is only the proximal sealing zone to see for 1A endoleak and DSA. Stop breathing. You are ready? Maybe I think you just move little bit above also you show. Little above. And maybe this side little. Yeah, okay, right.
Okay, breath hold. Right, okay.
It's very important to have a prolonged cine to see the delayed endoleak. Start breathing. So what's your comment on this?
You don't see, I mean, previously also we didn't see a sac, so, but as such now visualized and you don't see. That outpouching is not there and you don't see any delayed dye filling also.
Now we'll go for a distal landing zone
So
to
there
see
is
the...
no endoleak in the proximal segment. Now we will concentrate on the distal landing zone.
So we ruled out
down also.
1A endoleak. Now we are going to check the 1B endoleak. Okay. Breath hold. DSA, right?
Okay. So you don't see any dissection or any endoleak from the distal end also. And
Now,
we have covered the aneurysm completely. I think we have done.
now my question maybe it's a basic question in the fellow's mind or in the general physician mind. Should we need to put a graft for a thrombosed aneurysm where the lumen is absolutely okay and there is no tension on the aneurysm? Is a graft is at all required? Because after seeing that second question, where is the location of the aneurysm, just strike my mind. I think somebody is trying to ask,
Yeah.
is it all it is required? So maybe
See, the cell size of this stent is very large. So that area of thrombus will still be exposed and you can still have embolism, thromboembolism phenomena. Now we have totally excluded the aneurysm and the thrombus. So patient is safe. Always patients with aneurysm, even if they have a thrombus inside the aneurysm sac, it can always migrate, come down and embolize. In the arch, it is dangerous. It will go to the neck vessels and cause stroke. But lower down in thoracic aneurysm, it will go down into the foot and cause your carpal tunnel syndrome or leg ischemia. Hence, it is always better to do a covered stent in an aneurysm.
so not necessarily aneurysm, even in acute aortic syndromes like penetrating atherosclerotic ulcer, also it is an indication to exclude. So definitely there is no question at all here. It has to be excluded to prevent thromboembolic complication and also to prevent the future rupture of the aneurysm. Okay, we will address these questions later. So shall we? So in the meantime, while we are pulling out the device, we need to close this access. So should we do a dry closure by putting opposite balloon, or we will do a wet closure?
Well, since we have 3 proglides, we'll do
a wet closure, right?
Closure.
We will remove it after this. We'll take a shot.
Yeah. So now what size sheath are we going to take? 20?
There is a one 14 French is there, 12 French. That is, I think, more than sufficient. We will downsize to 12 French. We will using a pro glide. Then we will take a. So now we are going to first downsize this 24 French into a 12 French or 14 French using these 3 pro glides. You can see we put these pro glides in order. The leftmost one to my hand, otherwise the patient rightmost right hand, this one is a 10 o'clock and this is a 2 o'clock and this is a 12 o'clock. The order is 10, 2 and 12. The same order we are going to
14,
do it.
14.
Hold the wire. Yeah, you hold the wire and remove it. Okay.
Okay, 14 French sheath ready? Yeah.
No, yeah, first give me a 14 French sheath, then we will do all these other things.
Okay, now this is the important point where the groin has to be compressed well. There's a 24 French rent in the common femoral. Sheath fast.
The common femoral artery size is here almost like 9.5 to 10 millimeter. Hence, I think we can leisurely put 3 proglides. Suppose if the common femoral artery size is little lesser, what is your strategy, sir? Suppose 3 proglides are going to constrict the vessel if you feel.
Yeah.
How you are going to manage in the particular situation?
Then I would use 2 proglides and then assess for bleeding after the 2 proglides. In case it can get arrested by 2 proglides, I leave it as such, or else we can do a hybrid closure. We can put an angiosyl. Third, we can put an angiosyl if required. So then I would use 2. I mean, normally when you close with the closure devices, you have 20% narrowing of the vessel. So in a big vessel, you can accept it. In a small vessel, it might be difficult to accept. So then I would go for 2 proglides.
So first, I would like to remove this stiff wire out of this device. So Ashish, can you take a JR and bring this stiff wire out and we can exchange it to a 035 regular wire. So I think up till now only 2/3 of the procedure is over. The most important thing, last 1/3 of the procedure is going to be the access management.
Large bore access, anything beyond 12 French, we call it as large bore access. One has to be very careful in large bore access because the
Show above.
complications are more, almost 15%. And if you land up with the complication with the access side, the morbidity and mortality of the procedure increases, even if you have done a successful endovascular procedure. So we have now exchanged the super stiff Amplatzer wire to a Teflon wire with the
Maybe we
help of a
can
pigtail.
keep this. Show the down. Come to AP. Show me down. We will come out of the graph, the wire, not. Yeah, I think this should be the okay
Yeah.
position. Okay. Can you flush this one? And let us take one AC, or we will reverse. No, 8,000 we have given. We'll reverse. 5 ml protomy and some avil hydrocortisone for protomy.
அது ஓகே சரி சரி அப்போ நான் அப்படி போய்டுறேன். Okay, now we will show you the closure of the 3 proglides.
Okay, now can you reduce this 12 French to a 7 French? Give me a 7 French sheet. Yeah, Ashish, you can remove this.
The proglide has 2 suture threads. One is the blue one, longer one, which is known as the rail suture, and the other one, white one, which is known as the non-rail suture. The blue suture is used to push the knot, and the white one is used to lock the knot. Locking of the knot should be done lastly before you are removing the sheet and wire.
You wait 1 second. You take care of this one. Yeah, I will hold this. Remove your hand. Remove your hand, you put 7 French. So now we are downsizing to 7 French. Now that will be last. I think it should, usually it will get controlled. Wait, 2 things. Hold it. Okay. Remove this one, sir. Yeah. Give it to me, sir. Okay, no problem. Okay, now one of the proglide get cut. So we are going to manage with 2 proglides and 1 angioseal.
The 12 o'clock proglide suture wire got cut.
Okay, Ashes, can you remove this dilator first? Keep only the sheet. Keep the wire. This also get. Sir. Hmm? Okay, we'll go for a dry closure. We will remove this pigtail. Give me some balloon. And give me one 8 French angiosyl, please.
இது சந்தானம் opposite iliac size என்ன?
You give me 10 millimeter, 10 millimeter balloon.
11 okay. Or 10 millimeter
10 or even
balloon.
12 also we can take, sir.
10 or 11
So you have given protamine, right? 5 ml. 5 ml. Huh? No, first give me one 8 French angiosyl. Okay, leave that. You just connect the pressure sir. Okay, right. Just to put 8 French angiosyl over this. Ashish, you make this ready.
balloon.
Shall we put 2 angiosyl in this particular case? We will make this wire into 2. Huh? And I will put a 2 angiosyl because 2 proglides get cut. Huh? So, no, the hole is big, no, it won't. So, no, yeah, you put this angiosyl wire through this. Oh, the 8 French. I think it's a bigger size. Okay, 2 wires are there. Now you put through this particular wire on proglide. You are ready with the one angiosyl? So now put through this one. One second.
இது
Once again, give me another angiosyl over this. Listen, sir. Comfortable. No. இதை ரெடி பண்ணுங்க angiosyl. இல்லைங்க இதை ரெடி பண்ணுங்க இன்னொரு விஷயம். Open the next 8 French angiosyl, please. So if any pressure supports are there, you little reduce the pressure support. Maybe 10 millimeter mercury.
அந்த சைடு டக்குன்னு ரெடி பண்ணுங்க.
Hold the wire.
ஒரு 7 French ஷீட் இருந்தா கொடுத்துருங்க. எது இது எதுக்கு?
Okay. First give me one angiosyl. Give me another angiosyl. Put it through this. ஓகே ஆஷிஷ் இதை மட்டும் கொஞ்சம் இந்த 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 பக்கம் வந்துடுங்க.
Yeah.
லீவ் யுவர் ஹேண்ட்.
ஒரு டெஃப்லான் wire போடுங்க.
Give me a knot pusher.
Ashish, fluoro. Okay.
Leave your hand. Leave your hand. Leave your hand. One second. One second. எனக்கு show me that view. Yeah, leave your hand. I think I can get control. So just 1 second, sir.
நம்ம அந்த சைடு பலூன் வச்சுட்டா ட்ரை
Nothing, sir. Nothing, sir. 1 second, sir. Hold. Just press. Yeah. Give me the scissor. Remove your hand. Remove your hand.
இன்ட்ரோடியூசர் கூட இன்ட்ரோடியூஸ்.
இந்த பக்கம் ரெண்டுத்தையும் போட்டு கட் பண்ணிடுங்க. ஜஸ்ட் ரெண்டுத்தையும் ஹேஸ் எவ்வளோ போட்டு கட் பண்ணிடுங்க. கட் இந்த ரெண்டுத்தையும்
இல்லை வில் அக்ளூட் ஃபர்ஸ்ட் ட்ரை க்ளோஷர் பிகாஸ் யூ டோன்ட் வாண்ட் டு லூஸ் பிளட். அந்த ஷீட் சேஞ்ச் பண்ணலாம். நீங்கள் அந்த ஷீட் சேஞ்ச் பண்ணுங்க. கிவ் த 7 French 8 French.
Give 3 ml more protamine.
Ah, 7 French ready.
Give me a scissor, brother. Give me a scissor.
இது ஷார்ட் ஷீட்டே எடுத்துக்கலாம்ல, இது கிராஸ் ஓவர் ஷீட். ஃப்ளூரோ ஓகே. wire கீழே எடுத்துட்டு
No,
go
you
to the
have to
opposite.
put a crossover sheet.
Cross
No?
on. Yeah. Now go to the opposite side.
This is dilator with the dilator. No. Remove the dilator.
இல்லை, come back. Pass the wire into the opposite side.
That only we can do with the
கீழே
JR.
காட்டுங்க, ஒன்று கீழே காட்டுங்க.
I think we need to take a JR, sir. We will place the sheet there, take a JR, pass the wire, cross it, then only we can put the dilator and cross.
Sheath back. Only wire sometimes you can cross. Try to cross the. Go into the.
The angle is not favoring, sir.
Okay.
We have to put a JR. No problem. Remove the dilator and the wire. Keep the sheet there. Don't push keep the sheet there itself. And then take a JR. With the JR, you.
JR. JRR IMA ఏదో అనుకో. So what we are going to do is put our contralateral sheath, then take a 10 balloon and occlude the right common femoral artery for a dry closure, and then we'll try to close the access.
Do we have a cover stent? What cover stent we are having? Now pull back the sheath down.
A little back. Yeah.
Yes.
ಇಲ್ಲ ಹಿಂಗೆ தான்.
Or you can take a shot and you can go, sir. This is too low,
Okay.
sir. We have to go up.
I'll give a die. No. Up. Push it up. Go up. Gently. ಹಂಗೆಯಾ ವೈರ್ one minute.
Sir, Covera, what is the size available? Covera, what size? Prabhu said Covera is there. So what size right now we are having cover stent? 8 millimeter. 8 millimeter diameter may not be sufficient, I think, for this femoral.
9 we have. Okay, give that balloon 9 millimeter balloon.
Yeah, show down. Pass the wire, go beyond the femoral. Yeah. Now show above. No, first fluoro, please. Push the crossover maximum to get a control. Yeah, okay, right, okay. Why you remove the wire? Is he getting awake or what? Because pressure அதிகமாகுதா pain. So I think this is there is a question. What are the potential complications? This is one of the potential complication. What happened? We put 3 proglide and 2 proglide get cut. Only 1 proglide was intact finally. So that one ProGlide is holding. To support the closure, we put with the one wire we changed to two wires and we put two angioseal, two 8 French angioseals and one ProGlide. And we reverse the heparin. Now we are going to, for additional protection, we are going to balloon tamponade the access site for 15 to 20 minutes. Usually it will get settled. If at all, if it is not getting settled, then the options are, one is a covered stent, another one is a surgical exploration. So what's the size of this balloon?
10.
So I will go across the site. So, sir, hold the wire. I will push. Yeah, that should be little proximally. Yeah, that should be okay, right? Okay.
I'm going up. 2, 4, 6. 8. Okay, this should be enough.
So I'm slowly releasing my hand to see whether the blood spurt, how it is going to be. I couldn't see any blood spurt here because the balloon is occluding there probably. And put a timer on. Okay, timer is going on. We are going to keep it for at least 15 minutes now to check whether whatever the minor woos has stopped or not. We reverse the protamine completely and occluding for 15 minutes. Two angioseals are there and one ProGlide. Most likely it should settle down. Eye up little bit. So I think this is a site of puncture. Can you adjust the light to show the site of puncture clearly? Okay, this is a site of puncture. Okay. Softer than. Softer than. Some subcutaneous ooze is there, it will come out. Other reasons. So this is known as a bidirectional tamponade. So one is occluding from the inside balloon and we are giving gentle compression from the outside. And after reversing the heparin with the one ProGlide 2 angiosyl support with the bidirectional tamponade, most likely 99% it will settle down. If at all it is not getting settled, what is your next option regarding covered stent across the joint, sir?
No, that's all. That is a little bit concern. Keeping it at it's a no stent zone, coronal femoral artery. When you place a stent, when he flexes his hip joint, it can get crushed. So you'll have to think twice. Or else the other option of surgical closure is also there. We can always ask the surgeon to close the rent for us. Since like usually we puncture it a little above so that you can place the covered stent above the bifurcation. So one anatomically that should be possible. Only then we can put a covered stent. If you have to bring it down into the profunda femoris, that's not possible. So that is why we do puncture always 10 millimeter above the bifurcation. If we have a puncture 10 millimeters above, then covered stent is a possibility. Usually very elderly persons, you can do that. They are not going to flex their joint actively. But younger person, I would prefer surgical repair.
Even while calling the surgeon, we can always do a balloon tamponade and call the surgeon to
now,
avoid the panic situation.
Now that we have done balloon tamponade, we are not worried about blood loss or hemodynamic compromise. The surgeon also has the time to do the repair.
Is there any role of thrombectomy? Aneurysm thrombus. Is there any role of thrombectomy is the next question.
No. I mean, as such, there are no case reports or studies done where they have tried to remove the thrombus. The thrombus burden is extensive. It might not be fresh thrombus. It will be very difficult to remove thrombus. So that has never been done. And aneurysm with thrombus.
Are you able to balloon expand this stent if there is a need?
Usually we with the coda balloon we try to approximate the proximal and distal edges. You can
Good.
do balloon expandable, but one has to be careful that you shouldn't dissect the aorta.
Would you consider embolic protection with the Sentinel or similar devices?
Yeah, when you are doing landing in 0 or 1, where the neck vessels are involved and patient has thrombus in the arch, then one can consider
Wait.
cerebral protection devices.
Okay, who makes this stent prosthesis? I think there are different companies make stent
Yeah,
stent
there are many
prosthesis.
companies like this one we are using is
Go
Medtronic,
above.
then there is Cook, Gore. There are many companies coming out with.
Is there is any significant iliofemoral disease? No, in this particular case, there is no significant iliofemoral disease. Is the device migration an issue?
Yeah, that can happen. That is why you should oversize the stent properly. You should at least oversize by 20% for an aneurysm and 10% for a dissection. If you don't oversize the size, the stent migration can happen and then you will require a second procedure. We have done cases which were done outside and the stent migrated and then we had to repeat another procedure.
What anticoagulants and antiplatelets do you use?
Anticoagulants during the procedure, we give heparin to bring a ACT of 200 to 250. Antiplatelets, we use dual antiplatelets. But single antiplatelet also is more than enough for a large graft in a thoracic aneurysm.
Are stent fractures a threat in such long device? Definitely no, because these are self-expandable devices. All the self-expandable devices are made up of nitinol, so definitely stent fractures are not a threat. Is the patient sedated? Yes, the patient was intubated. We are doing under general anesthesia. As such, there is no general anesthesia is required for this particular patient because we are dealing with the thoracic aorta. What do you think, sir?
Yeah. You can do it under conscious sedation also. It's not a must that you should do it under GA, but procedures which involve the arch of the aorta and nursing the aorta, it is better to give general anesthesia. We'll be doing a CT. I mean, aneurysms has to be followed up frequently. So we'll be doing a CT angiogram after 1 month, 6 months, and then 1 year, and then yearly thereafter.
When would you time PCA of the LAD? I think we discussed at the initial part of the procedure. This is a chronic coronary syndrome. Hence, we can always stage the procedure, or even we can discuss the optimal medical management versus the PCA, because that was not discussed with the patient up till now. Always we want to discuss with the patient about the choice of management. Is it MRI compatible, this device? If at all
Yeah.
compatible, when you will suggest? After how many?
I mean, in the initial first 3 to 6 months, if you are doing an MRI, it is better to do a 1.5 Tesla MRI. After 6 months, you can do even a 3 Tesla MRI. So MRI can be done.
Is there is anti-thrombotic coating of this device?
No, there
Okay,
is no
next.
anti-thrombotic coating on this device.
That's all. Next. I think that's all the questions we can see in the chat box. So now the timer showing us 7 minutes 25 seconds.
We'll deflate and see at 10.
Okay, we
10
will see
minutes.
at 10 minutes.
Because we are reversed with we are reversed the heparin with protamine. This blood should not, this balloon should not get clotted. So at 10 minutes we'll deflate, then look for ooze, and then try to give an injection from the right common iliac and see the status of the access site.
கை வலிக்குது இங்க வாங்க அழுத்தி பிடிக்கணும்.
So pressures are stable. It is 124 by 83, heart rate of 61, saturation is 100%, patient is hemodynamically stable.
Brother, see everything okay, no? You have to give a gentle compression for 30 minutes here itself. Okay? Till 30 minutes, don't shift the case. After that, you put a tight pressure bandage, then only you are shifting the case. Okay?
Okay, 10 minutes is going to get over. Now we are going to deflate the balloon under fluoroscopy.
Can you feel the pulse, Ashish?
Okay, at least we have no visible ooze from the groin side. So we'll remove the tamponade balloon and then we'll take a catheter there and give an injection and
Can
see.
we give the injection through this? This is over the wire balloon, and can we check?
Uh,
It will give some contrast, but it may not give a good contrast.
we'll remove it since it's not
Okay, right.
bleeding. Sheath, hold the sheath.
Otherwise, we will take an injection through the sheath.
Sheath also.
Pulse liya hai. Huh? Yeah, wire is there, not to worry. Okay. One flash. Okay, so now we can feel the pulse. Give
Sure.
me contrast. Number, I think, pitch. Number two, don't do bench press. Okay, we're going to take a shot. Okay, ready?
Show
Flow.
the.
Ah. So we can see absolutely a clean femoral artery with a good superficial femoral flow. And you can see here the site just high up. You can see the site here. The site is well controlled. So this is how when the one or two proglides get caught in a large vessel access, we can use the collagen based device and bidirectional tamponade to manage the vascular access complication. Over to Adilan, sir.
Yeah. So I think you should be happy. We don't see any residual defect also. Having used three closure devices, the flow is good, pulses are good, patient is hemodynamically stable. So I think we are through with the procedure. So I would like to thank my associate consultants who helped me, Dr. Nandakumar and Dr. Ashish, to carry out this endovascular closure of the thoracic aortic aneurysm. I'm also thankful to the entire cath lab team for their help. In spite of having faced access site complication, we could manage it and come out well.
Most importantly, I thank our anesthetist, Dr. Nitya Kumar, and his team to make this procedure as a clean and neat procedure. the bladder, you see, sir.
Hmm.
Sir, it's like pulsating.
Uh,
You can see the bladder,
uh,
the pulsating. Why bladder is